Ladies and gentlemen, I would welcome you to day 2 of the Glasgow meeting of the Society for Endocrinology BES. And it's my great pleasure this morning to introduce the CET visiting professor. Professor Chris Thompson graduated in medicine from Dundee and then did MD studies in Newcastle before a brief spell in Edinburgh, a sojourn to San Francisco, returning to the UK again to visit Glasgow before being appointed in his current position as consultant and professor of endocrinology at Beaumont Hospital in Dublin. Chris needs little introduction to most of us in the room. He is a wonderful clinician, a clinical scientist of great reputation, a mentor to lots of his trainees and people who are scattered around the world. And somehow, amidst all of that, he's managed to find time to be the clinical and scientific committee member of the Gaelic Athletic Association, which I'm sure we'll hear about later this evening. It's said that you can go to anywhere in the world and meet an Irishman, and it's said that you can go to anywhere in the world and meet a Geordie. Professor Thompson is both, and I'd like to welcome him to give this morning's plenary.
Thank you, Steve, for the kind introduction, and thank you to the Clinical Endocrinology Trust to have asked me to be the visiting professor this year. I've had a fantastic 10 days touring a number of centres throughout England and Scotland. I'd like to thank very much everybody who has been there for the hospitality that I've been shown. And I'd have to say that one of the greatest things about it was seeing all the young people who've presented cases at Newcastle, Oxford, Birmingham, Manchester, and Glasgow, and certainly gives me a lot of hope for the future of endocrinology. I don't have any conflict of interest. And I'd like to start by particularly thanking Steve for, when we were in Newcastle, inviting my mentor, Peter Bayliss, who took me as an SHO to do my first research steps, and he's well into retirement now, but I'd like to take the opportunity to acknowledge his mentorship and his guidance in the early years of my career. I'm particularly pleased to be back in Glasgow, where I did my first consultant job. Billy Connolly, who is a native of this town, wasn't always the kindest in his descriptions of the town, and I certainly wouldn't agree at all with this. Anybody who's taken the opportunity to look around Glasgow will know that there's fantastic architecture in the university and George Square. There's a lot of fine watering holes that to slake your thirst, some fine sporting emporiums, well, one anyway, and some great countryside. And I would think my view of Glasgow actually was more in line with this from a character in Alistair Gray's great book, Lanark. My job today is to talk you through the last 60 years, or 61 now, of SIAD. And it's worth remembering that the first clinical description of this syndrome that we all diagnose on a daily basis in our clinical practice only came in 1957. And reading these old papers is a real reflection on what medicine was like. In this paper, they reported the cases of 2 patients with small cell carcinoma of the lung who had hyponatremia, and the description of their physiological studies, including 60-day admissions for water balance studies, really harks back to a gentler and slower time. In my role as clinical director, I certainly would be very unhappy if people did that now. But what they did show in a series of elegant physiological experiments, when they looked at these 2 patients with hyponatremia and manipulated the water intake to really quite severe restriction, you could see the changes in the plasma sodium, the increase in blood urea, and the decrease in body weight. And what they were able to show is that this was an effective way of, with very severe restriction of reversing the hyponatremia, and also that the infusion of normal saline had no effect on the plasma sodium concentration in these 2 patients. And on the basis of this, they formulated their idea that there was some hormonal substance that caused the retention of water at the level of the kidneys. And some of the lessons from these two index cases are still pertinent today. Small cell carcinoma is still one of the commonest causes that we see in clinical practice of SIADH. Things have advanced a wee bit, that we know that this is genuine ectopic ACTH. If you take tissue from the lung, it will stain on immunocytochemistry for vasopressin, and you can isolate messenger RNA for vasopressin in the tumor tissue. Key lessons are still there. Saline fusion is not an effective treatment for SIADH. And really severe fluid restriction, and this is the sort of fluid restriction few patients can tolerate, does cause an increase in plasma sodium concentration. The end of the study did report that both of the patients died. And of course, we now know from epidemiological studies that hyponatremia due to SIADH is a very poor predictor, not just in small cell carcinoma, but in all tumors throughout the body. And over the next few years, they formulated their diagnostic criteria for SIAD, and they're included here. And, in a sense, the quality of their original physiological studies mean that if we look at the changes in the diagnostic criteria recommended by the guidelines in 2013, really, there's not much change apart from a little bit of quantification of the qualitative diagnostic criteria that Barter and Schwartz originally suggested. The only one change is that their original diagnostic criteria of a response to fluid restriction has been dropped, though it still remains the first-line therapy for mild and moderate hyponatremia in both the American guidelines that I was involved with and the European guidelines that Steve was involved with as well. So you might look at this and say, well, what have you all been doing in the world of hyponatremia? That not much has changed from the original stuff that was published in the 1950s and 1960s. And that sort of journey is something I'm going to take you on today. So what has changed in 60 years? I think one of the biggest changes that happened initially was the ability to prove the presence of an antidiuretic hormone after the development of sensitive radioimmunoassays by Gary Robertson in Chicago, and subsequently my old mentor and Steve's old mentor, Peter Bayliss in Newcastle. And using the new radioimmunoassay techniques, the physiological properties of osmoregulation were able to be defined. This is stuff that I did when I was still in SHO with Peter Bayliss, showing that if we infused hypertonic saline, there was a linear relationship between plasma osmolality and vasopressin. And if we measured thirst on the visual analog scale, exactly the same sort of linear relationship with a similar threshold for the onset of vasopressin secretion and the onset of thirst. And we were also able to show in a series of studies that was performed by Dermot Smith, who was one of my fellows, that there was a very erratic relationship between vasopressin and osmolality in patients with SIADH. But interestingly, that at levels of plasma osmolality where thirst should have been suppressed, thirst was maintained in SIAD with a lowering of the set point. And of course, this is one of the things that makes fluid restriction so difficult, because thirst is not suppressed. So patients with SIAD, even though they've got hyponatremia, continue to feel thirsty and to desire to drink in excess of what the fluid restriction is. And I think as well what the ability to measure vasopressin told us in SIAD, that although in the vast majority of cases the hyponatremia was due to increased plasma concentrations of vasopressin, even in this early study in 1982, there were a certain number of people who had vasopressin levels which were very low and sometimes below the limit of detection of the assay. And this was explained in a key description of patients who presented with hyponatremia, had undetectable vasopressin concentrations, but who had mutations in the V2 receptor in the renal tubule, activating mutations, which meant that they would respond with generation of aquaporin-2, the water channel, and reabsorption of water, even in the absence of vasopressin. And one of the cases that was presented to me this week on my grand rounds was this case of an adult female who presented in exactly that way in Cambridge and was diagnosed by a bright senior registrar as having this unusual mutation of the vasopressin receptor causing hyponatremia. And it's because of the recognition that some cases of hyponatremia have suppressed vasopressin levels that the terminology has changed from SIADH to SIAD so that you incorporate those causes that are not hormonally driven. Well, what we now know as well from a number of studies is that hyponatremia of all causes increases mortality, and this is a prospective study conducted by one of my fellows in our hospital comparing the mortality of inpatients admitted to our hospital in SIAD and hypovolemic and hypervolemic hyponatremia. And probably not surprisingly, although all three groups had higher mortality than eunatremic controls, the mortality in SIAD was less than it was if your blood volume is either increased or decreased. And to a certain extent, this increased mortality was related to the severity of the underlying diseases causing hypovolemic or hypervolemic hyponatremia. But in the SIAD group, the Charlson Morbidity Index, which is an index of clinical comorbidities, were actually higher in the normonatremic than in the SIAD group, providing indirect evidence that perhaps it's not just the comorbidities that cause the excess mortality, but some of it is due to the hyponatremia itself. So, in terms of those diagnostic criteria, has anything really big changed over the years? And the one that I just want to talk about, because I think it's of really significant clinical importance, is this criteria here about the need to exclude particularly adrenal failure before making a diagnosis of SIAD. And work in our unit, we work very closely with the National Neurosurgery Unit in subarachnoid hemorrhage and traumatic brain injury, has suggested that, in fact, a number of patients who present to us with hyponatremia in the neurosurgical unit might have that hyponatremia which, due to acute ACTH deficiency. So hyponatremia is pretty common in patients with SIADH. Retrospective and prospective studies have all shown it occurs in about 50% of patients, and 90% in this prospective study that we did of over 100 patients, it was due to SIAD. But interestingly, 10% of those who presented with SIAD had evidence of acute ACTH deficiency with low plasma cortisols, and on subsequent testing, when the patient had recovered with low cortisol levels in response to dynamic testing. And a similar sort of thing in traumatic brain injury, less of them develop hyponatremia, and again, our original study suggested that most of them were due to SIADH, but in fact, when we followed them sequentially with 9 AM cortisols, as well as renin levels, vasopressin levels, ANP levels, over 80% of those hyponatremic patients developed low cortisol levels during a time when they were in ITU, they were on pressor agents to keep the blood pressure up, and you'd expect the cortisol levels to be very high. And a lot of these patients responded with reversal of their hyponatremia with steroid therapy. And if we look at the slightly unusual or rare condition of idiopathic isolated ACTH deficiency, we published this as our index case from the Irish, index series from the Irish Pituitary Database. 9 out of 23 of these patients actually presented with hyponatremia, and 2/3 of these actually had multiple admissions to hospital with hyponatremia attributed to drugs or to SIAD before finally they happened to be admitted under a pituitary endocrinologist who put 2 and 2 together, measured the cortisol, and worked out that this recurrent hyponatremia and recurrent illnesses and admissions were actually due to cortisol deficiency. And so we were interested to look at this in a large prospective group of patients coming into our hospital, and Martin Cuesta did this work. He looked at almost 500 patients with euvolemic hyponatremia presenting to the emergency department, and what he found that within this group there was a significant minority who were presenting with steroid deficiency. And there was 2 broad categories: people who were genuinely presenting with new hypopituitarism, but also a significant number in whom there was adrenal suppression due to exogenous cortisols, glucocorticoids, either patient who had just finished a course of prednisolone for polymyalgia rheumatica and had it stopped, or patients who are on steroids already but did not have an increase in the stress dose of steroids in response to an acute illness. So these might be people who were on 5 milligrams of prednisolone for rheumatoid arthritis, developed septicemia, and didn't have stress dose of hydrocortisone. But they also included, and I think this is really important, a number of patients who are on high-dose inhaled steroids. And Conor Wood's paper in the European Journal of Endocrinology a couple of years ago did show that 25% of patients on long-term inhaled glucocorticoids fail to respond normally to a synaptin test. And I think this group of patients is one that is potentially vulnerable to adrenal crises and hyponatremia if not treated with stress steroids. So in our group, 4% of patients presenting with what we thought in A&E was SIAD actually had steroid deficiency, which is 1 in 25, and it works out as 1 patient every 2 weeks presents to our emergency room with SIAD, but actually have clinically significant steroid deficiency. Interestingly, no patient had undiagnosed hypothyroidism, and I think one of the other things that we might be thinking about changing in the next set of guidelines is dropping the need to exclude hypothyroidism before you make a diagnosis of SIAD. So the steroid business is important. This is a case who came in to us, 55-year-old man who came in. He was very sick, vomiting, decreased conscious level. He'd had a recent colonoscopy, and on admission, he was hypotensive and tachycardic. He had really pretty bad hyponatremia, and he had worsening renal failure, which my guys treated with IV fluid challenge, antibiotics. When I saw him the next day on the post-receiving ward round, he really hadn't got any better. He was now in AFib. Blood pressure was still down. He was anuric, and the guys were going, "We're going to get the kidney boys to come and see if he needs dialysis." And I said, "Well, let's have a look at the sodium, lads. Is there any medications that could do that?" And when we actually got his chart out, the story was, in fact, he had a long history of what sometimes gets called burnt-out rheumatoid arthritis, being looked after by his GP. He was on long-term prednisolone, literally for decades, at a level that we know that would cause adrenal suppression. He'd actually, before his colonoscopy, been told by the surgeons to have a 2-day bowel prep and take no medication at all, including his prednisolone. So he was steroid deficient then. They inflated his colon with gas, and he felt a bit sick and started to vomit. And the combination of this is that he couldn't take his steroids after the colonoscopy as well. And when he came into us, a random cortisol was in his boots, immediate response to IV steroids, and his creatinine fell significantly just with appropriate stress dose steroids. And you can see what his synaptin peak was on recovery. This guy had no real endogenous adrenal function. And that prompted us to go into the clinics with the agreement of our colleagues, looking at patients who are on prednisolone for renal disease or respiratory disease or arthritis, etc., and compare the knowledge of the sick day rules with our own patients here. This doesn't look great. For us, it was still about 90%, though, in fact, all of our patients have documentation in the notes to say that we've discussed this. But look at the knowledge of sick day rules in people on long-term immunosuppressive steroids. none at all. You could take the view that teaching patients about this is the responsibility of the prescribing consultant, but I suspect we might have to take the lead in our own hospitals in persuading our colleagues to talk to their patients about the sick day rules. So consider cortisol deficiency in SIAD. First of all, if anything's happened to the head. Secondly, if somebody's on steroids, including inhaled steroids. And just a reminder that, as I say, one patient in every 2 weeks in our hospital, 600-bed hospital, just the same as the ones that you work in, presents with SIAD, but it's due to cortisol deficiency. So this is not really small print stuff. So are we any good at it? This is Pierre-Marc Boulud's paper looking at routine clinical practice in London. This is Joe Verbal's prospective study of patients who were only allowed in if they were admitted to the study by an SIAD specialist who had done all the workup. And this is our prospective study of, in a research sense. And look at the rates of cortisol measurement. Routine practice, 1 in 3 people have a cortisol measurement for hyponatremia. In this study of SIAD, 1 in 3, and even in our prospective study where we try to get every bit of information, it was only 90%. So certainly I think we could be better at looking for steroid deficiency in hyponatremia. So should the diagnostic criteria change? I think this should be really emphasized, but whether we need hypothyroidism there as well, I'm not sure. So what about management to finish off? The management options have been delineated in 2 of the major guidelines, Steve's guidelines from the European group and the American and Irish guidelines in the American Journal of Medicine. And when you look at somebody coming into our practice, I think everybody would agree that the first-line treatment we probably would use was fluid restriction. Certainly the Europeans felt that this was important. And in a rare agreement between the 2 sets of guidelines, Steve, the Americans also felt that fluid restriction was the first-line treatment for people who had no or minimal symptoms. And we're all evidence-based physicians, so what was the rigorous database that these 2 sets of guidelines depended on? Well, this is the only one that I could find on a Cochrane analysis looking at the impact of fluid restriction. If we look at the group down here, 14 patients randomized to fluid restriction, 10 died within a day, 1 died at 70 days, and 3 people ended up in institutional long-term care. That's the evidence base that you and I use and that the guidelines thought was reasonable for the implementation of the first-line treatment for SIAD. And if we think, well, okay, that doesn't look very good, but surely it works, well, I'm not sure about that either. This is the SIAD register, the data published in 2015. This is real-time treatment in clinical practice, and the increase in sodium over the first day was actually not statistically different in those allocated to fluid restriction compared with those with no treatment. And in fact, the only ones that hit the target of getting the sodium up by more than 5 were either hypertonic saline infusion or vasopressin receptor antagonists. So we know that patients don't like it. We know that they find it hard to stick to it. The evidence base really is pretty flimsy. So why is this response to fluid restriction so disappointing? Well, I think we can get clues before we start patients on fluid restriction. And there are a number of predictors of whether you respond well to fluid restriction or whether you respond badly that were documented in the American guidelines: low urine volume, high urine osmolality. These are both pretty good reflections on how much vasopressin you've got around. And the first equation, which is the ratio of urine sodium plus urine potassium over plasma sodium of greater than 1. And in this study, which we looked at 180 patients who are well worked up with full diagnostic criteria for SIAD, 50% had low urine volumes, 40% had a high urine osmolality, and 1 in 4 had a first equation up over here. So 60% of patients had the presence of one predictor and 40% two predictors that will tell us that our patients wouldn't respond to fluid restriction. And I use these predictors now to make a decision when I see somebody with SIAD whether I'm going to embark on fluid restriction or whether I might move faster to second-line therapy. So the key clinical message is that the database supporting the use of fluid restriction is virtually non-existent. The SIAD register suggests in clinical practice fluid restriction is no better than no treatment. We're actually now doing a randomized prospective trial in my own unit to challenge this. 60% of patients have got predictors that will tell us before we start fluid restriction that it isn't going to work. And of course, it's difficult to implement and maintain compliance, both as an inpatient, but particularly when the patient goes home and has to mind themselves. But the problem is the alternatives are not easy, are they? Doxycycline we're all a bit wary of because it's got variable efficiency and lots of side effects, as well as no evidence base, no license. Urea is much beloved of Belgian physicians, but when, there goes my pointer, but when I persuaded my pharmacy department to buy some in and make some up for me, I got a phone call when it arrived to say, would you come down and have a look at this? There's a great big sack of urea, exactly the property, the stuff that I was told to buy by the Belgian physicians, with a big stamp on it saying, not for human consumption. So there's no randomized data for it. There's a number of retrospective studies which do suggest it works, but you have to get your pharmacist to make it up. And apparently I hear that it tastes pretty much like you'd expect it to, like Belgian beer. My renal colleagues who are good clinicians and physicians do talk fondly of the combination of furosemide and oral sodium. The furosemide to cause an aquaresis and a natriuresis, and then the oral sodium chloride to replace the sodium. And this physiologically makes sense, but again, very little in the way of data in terms of randomized controlled trials to support it. And the Vaptans, of course, which do have prospective studies and which are effective, are so expensive that for most of us, they're priced out of day-to-day use. So the alternatives need to be developed, and I think until we get marketplace competition for tolvaptan to bring the price down, we're still going to be stuck a little bit. This is the data from the SALT trial, SALT 1, SALT 2, one in Europe, one in America, showing that if you compare tolvaptan against placebo, this was a mixed group of SIAD and hypervolemic hyponatremia, a significant rise in plasma sodium, which when you stop the drug at the end of 30 days, the sodium drops back down to normal. So there's no doubt at all that this works and is very effective. And so I'm going to finish in the last few minutes to talk about some changes in the emergency management of acute severe hyponatremia, the sort of thing that our NCHDs see in the emergency department. And, you know, when we look at this sort of case, a 48-year-old man who comes in with A&E, he's got what looks like SIAD, but his plasma sodium is 113, he's seizing, he doesn't regain consciousness. You know, if we do nothing, we know from ARIEF's data and other data where the fluid restriction was effectively no treatment, that this is a really bad condition. There's a mortality of 60 to 90%. You know, you compare that with the inpatient mortality in my hospital from an MI, which is 8%. But if we don't treat this condition in which there's cerebral edema and raised intracranial pressure, the patient could die. But sometimes people are paralyzed by action, the action being the acute elevation of plasma sodium with 3% saline because the fear of central pontine myelinosis or osmotic demyelination into doing nothing. And so there are very careful guidelines that have been developed, and there's one or two changes in these which I think are important to talk you through. These were our own guidelines from the American data, suggesting that we should have a paradigm shift about how we should look at the elevation of plasma sodium. And that's to try and look for initial elevation of plasma sodium of between 3 and 6 millimoles per liter over the first few hours to acutely rise plasma osmolality to try and draw some of the fluid out of the brain and reduce intracranial pressure. And these guidelines were on the basis of neurosurgical data showing that you could significantly reduce intracranial pressure by the infusion or the bolus infusion of hypotonic saline. So our recommendations have changed from the traditional IV hypotonic saline infusion that you and I would be used to giving boluses of 100 mils of 3% saline over the first 6 hours to try and get the plasma sodium up. Now, this is something that needs fairly significant monitoring. Plasma sodium measurements every 2 hours. It was said 2 to 4 in the guidelines. I think every 2 is what's needed. And there's been a slight change in the targets. So the traditional target for the first 24 hours was to try and get the plasma sodium up by no more than 12 millimoles per litre. Beyond that, you're into osmotic demyelination territory. The target rise has been lowered to 8 or less. And that's because there have been a few reported instances of osmotic demyelination occurring with intermediate rises in plasma sodium. And the reason for the target rise and the maximum rise, 8 and 12, is for medical legal protection, because anybody who deals with these patients know it's sometimes difficult not to overshoot. And slightly lower targets if you've got high-risk patients who are either alcoholics or malnourished. And this is the sort of thing to keep in your mind, that instead of the slow rise in plasma sodium that we would be used to having, that there'd be initial front-loading of that rise and then a gentler rise over the rest of the 24 hours. And I have some data that Aoife Garahy has collected as part of her thesis working with me. What she looked at was prospective collection of data in patients that we treated with bolus therapy compared with historical data that we looked at retrospectively from our cohort of patients who we treated with continuous infusion. These were only patients with SIADs because of our data showing the mortality is different according to etiology. And what it showed was that the data in the red is the bolus infusion, that at 6 hours there was a very significant difference in the plasma sodium, which was by 24 hours not any greater, so we hit our 24-hour targets, but there was a very important clinical advantage to getting it up early in the first 6 hours. And if we look down, sorry, I've lost my point, I've dropped it down the lectern here. If we look down 1, 2, 3, 4, 5 to the 6-hour Glasgow coma scale, it was significantly higher in the patients who we treated with bolus therapy and got that initial 6-hour plasma sodium delta up to 6 millimoles per litre. No difference statistically in mortality, but the one thing I would just say is that our own findings have shown that there was a slight increase in the need for overcorrection of plasma sodium in the group that we treated with bolus therapy. So you have to be a wee bit careful with that. Okay, I'll just skip this. So if we finish off then, Mr. Chairman, if we look at the changes then in the initial criteria for diagnosis of SIAD, there hasn't been a lot of changes other than putting some figures on, but I think to emphasize the absence of adrenal failure as an important diagnostic criteria to look at, and to remember that fluid restriction is often ineffective, and to consider rapid movement to second-line therapy. So 60 years of SIAD, the basic diagnostic criteria are largely unchanged from those in the early physiological studies, which just shows how well they were done. The association with SIAD with excess mortality is well established, and the recognition of V2 receptor mutations is an interesting development in a minority of patients. I think although fluid restriction remains first-line treatment, just as it did in 1957, it's often ineffective, and Vaptans are a significant second-line therapy. And just to raise the issue with the bolus therapy, which may provide a mechanism for improving the mortality that we see with acute symptomatic hyponatremia. I think it's important to sort of document that, the original studies were done by interested young researchers. I'm delighted that I've had similar interested young researchers who've been able to take on the field. And I'd like to take the chance to thank my colleagues, the two corners, Mark Sherlock and Bill Tomey, who I work with, my 3 research fellows at the top, and below this, the various fellows who have worked in hyponatremia research. And just for the young SRs and SPRs in the unit, 6 of these people have become professors since they started working in hyponatremia, so it's very good for the career. Thanks, Steve.
Chris, that was wonderful. I'd like to thank you again. It's been a long week. You deserve a rest, but well done. Thank you.